think we should explore a few solutions.
Grammarly's suggestions catch when your tone might undermine your message, and it offers suggestions to make you sound more confident.
Let's explore a few.
sink to your heart to find you. Open up your eyes till you're blinded by the lies, so you can see what you do. Christmas every time we start locking eyes up. Lost control. Oh, it's paradise with honesty, but I'm in the dead of the night. Teardrops on the floor. The pain is over. Feel the darkness take control.
No, there ain't no stopping us. Fly without boarding pass. Couldn't catch me, I be moving fast. Call me a shooting star. Let 'em know you are. Flying up in a bar. Wish on a star. Time to show 'em who's in charge. Call me a shooting star. Didn't even get to cross. I said I'm moving too far. Get to glass. Looking at a shooting star. Got more than a couple of people going mad. I swear they're rooting hard. Tell them I'd be big in the game like she went and got them breast implants. I said I'm moving too fast. Didn't even get a glance. I'm ready to eat up track like I'm seated in a restaurant. If you had swag like mine, you know it's best to flaunt. We aren't hating because you aren't. Shining like it's neon. Rock like kings of Leon. Shooting stars across the galaxy. I stand out, so don't be mad at me. Infiltrate, I'm with my strategy. When that's enough, then I just have to leave. Shooting stars across the galaxy. I stand out, so don't be mad at me. Infiltrate, I'm with my strategy. When that's enough, then I just have to leave. Yeah, shoot. Yeah, shoot. Yeah, shooting. Yeah, shooting shots. Shooting stars. Didn't even get to cross.
Good evening, everyone. Thank you for being here. Thank you for joining us. So today we are here to have a webinar on the forensic medicine.
I said I'm moving too far. Get to glass.
Guest is Dr. Balbir, she will enlighten us about the principles of medical ethics and its application to the clinical practice. So first of all, let me introduce her. And she is the HOD of forensic medicine in the Noble Medical College. She's also have the lifetime achievement award for the from JP Modi Lifetime Achievement, and she has done the uh, fellowship award from the Indian Congress of Forensic Medicine and Toxicology. She is also the lifetime achievement award from the
Hello. Uh, I think there is some technical issues. So sorry for the interruption. I think we have to wait for a while. So today our guest speaker is Dr. Balbir ma'am, and you all know that Balbir ma'am is from Noble Medical College, and she is also the HOD of Forensic Medicine Department. And she is so talented, and she has uh, attended many meetings, uh, published many journals, and she was the mentor of many students, many PGs, and so as you know that we have already published in our uh, promotion photograph that she has experience of more than 40 years, and she is also the uh, member of Punjab Academy of Forensic Medicine and Toxicology. She was the member of Indian Medical Association, and she was the ex-vice president in North Zone. She was also the ex-executive member committee of IAFM. She was also the member in advisory board, and she has done many things. And there are, I think, if we start to elaborate ma'am's contribution to this medical science and forensic medicine, then it will take a lot of time. So uh, before getting late, I think it's time to start this webinar. So I want to hand over this session to ma'am. And I think we will definitely have a great session, and ma'am will share her experience and uh, her knowledge to every students who are here. And I think this will very fruitful to you. So let's. I would like to call ma'am. Ma'am, please come and start this
Thank you,
webinar.
Vivek. Thank you so much.
And we are also
Uh,
thankful to you for coming on this webinar and accepting our invitation. So thanks a lot.
it's my pleasure, really. I'm so grateful that you gave me this chance to speak to the students and junior colleagues, some in the being or some are already the junior colleagues, probably. So it's my perfect and privilege to speak to all of you. So I'll start my uh, talk, the presentation. Sure. So, yeah. Just a second. तो नहीं है ये तो उनके लिए है तो क्या हो गया वो इग्नोर वाला बटन दबा दो इग्नोर पड़ेगा ये बहुत सारा स्क्रीन आ रहा है हटा के इसको full screen ये जाएगा वो दे दो फुल स्क्रीन इधर कर दो ये तो नहीं है why it is not responding क्या गड़बड़ हो रही है भैया
Hello? 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 ये सही आ रहा है आपके पे Okay.
Okay, can you hear me now?
Yes, ma'am.
Yes, okay. Sorry for the delay. Today's presentation is about principles of medical ethics and their application to clinical practice, which is where it is big talk about. First of all, it is the knowledge of medical ethics is required for a proper medical practice. We have to practice. So, for a proper medical practice, we must know what our ethics are while we are doing our clinical duties and other duties and medical legal duties for that matter. The ethics teach us about our duties as a medical professional. They provide privacy, confidentiality, and truthfulness in the doctor-patient relationship, which is again very, very important. Doctor-patient relationship. Unless this is there is good relation between doctor and patient. There's no point in treating the patient because they will not trust you. Next is that sound knowledge of medical ethics enables a health professional or us, the doctors, to apply these in real life situations. That means in our dealing with the patients. Knowledge of medical ethics is essential to avoid allegation of misconduct and medical negligence. This is very important these days because the awareness of patients, their rights, their medical legal rights, this is everybody so much aware of because of the media and other things. They are too much aware of their negligence so that we abide by them. It is legally and to avoid. Other is illegal act. That means doing things, illegal things deliberately. So when once we know our ethics, we will avoid doing all those things which are wrong actually, illegal and wrong. Ethics promote health, well-being, respect and decision making, dignity, justice and accountability in the medical profession, to be precise. What are the responsibility of a doctor, a practicing physician? The responsibility is just to name a few in different settings and situations. We don't get a single situation or single setting. We have different situations at different times. So at those times, we must make the correct decision in all the cases. The decision involves more than selecting the appropriate treatment or intervention. It's not only about the treatment, what appropriate treatment we give, or what intervention we do, what interventional, surgical, medical interventions we do. Apart from that, there is more than that. And this is inherent, the ethics are inherent and inseparable part of clinical medicine. So we must adhere to ethics because the obligations are, number one, the main obligations are to benefit the patient. Very important to treat the patient, and whatever we do should benefit the patient. Secondly, to avoid or minimum harm. In certain things, there is slight harm also. See, we should try and do the minimum harm to respect the values and preferences of the patient. There is a question by one of our difference between moral. The question are they are morals. What are morals? Are norms, that is personal beliefs and principles. Your morals can be different, my morals can be different. So they are personal beliefs and principles for right conduct, and they transcend the cultures, the regions, the place you belong to, different states in our countries, both Nepal as well as India. We have different cultures, religions with different religions have different morals, and other groups, identities, etc. So, but for all these, all the regions, all the cultures, all the religions, there are certain common morals. Like I have enlisted them not to kill, not to harm, or cause suffering to others. This is one of the morals which either one or all of them, some people abide by all of them, some people don't abide by all of them. So for them, their moral can be different than mine. So not to steal, not to punish the innocent, to be truthful, to obey the law, to nurture the young and dependent, to help the suffering, and to rescue those in danger. So these are the common morals which each culture, each region, each religion will teach us. Now, what are the bioethics and clinical ethics? The ethics, now I've come to the ethics. I'll tell you what ethics are. Advances in medicine and medical technology, number one. Secondly, the previously, not in the very recent past, but a little before that, there were medical interventions and research were done without informed consent, because even the patient didn't know their right. They did not know that they have to know so many things. So without telling them, we were doing medical interventions and even research. And also, much before that, then experiences and the stories from the World War II, that there were experimentations in concentration camps, etc. All these things, keeping in mind, they led to rapid evolution of bioethics. Bioethics about professional conduct and their codes. And this has come to its present status with an extensive scope, which includes the research ethics. We have different ethics for different things: research ethics, public health ethics, organizational ethics, clinical ethics. So all those problems which we have faced before, the stories which we have heard from others. So they led the evolution of bioethics to the ethics. There are 4 fundamental principles of ethics. Number 1, and these ethics, I'm not talking about one country, they are worldwide. They are not only in India, Nepal, or other neighboring countries. They should be followed throughout the world. Beneficence, that means treat only if it is beneficial for the patient. Non-malfeasance, that is refrain when the risk outweighs the benefit. When there's more risk than the benefit, we should not do such things. That is non-malfeasance. Autonomy, self-determination, that means listen to the patient. The patient has certain rights to decide for himself or herself. That is self-determination. And justice, equitable, equal distribution without discrimination. There should be no discrimination of any sort on religion basis, the region, language, rich, poor. So they should not be. So we should be justice to each and everything. The first 2, that is the beneficence, treat only if beneficial, and non-maleficence. These 2 can be traced back to the times of Hippocrates. That is, they are very, very old ethics, 2 ethics. That means to help the needy. Here, for needy for us is a patient, to help the patient and do no harm. Don't harm, do something which is beneficial, and if there is benefit which is less, help and to do no harm are very old, from the time of Hippocrates. But the other 2, they evolved later on. So in the previous books which were written about the ethics, and one of them is this perceivable book of a book on ethics in early 1800s. The importance of first 2, the keeping of the patient's best interest as a goal is stressed. But autonomy as 4 code of ethics is there are 4 principles which we must follow in our clinical practice while we are treating a patient, while we are taking care of the patient. So we start with the beneficence. Some explanation of each one of this. Beneficence. The principle of beneficence is obligation of the physician. That is, act for the benefit of the patient, prevent harm or remove condition that will cause harm. Third, help persons with disabilities and rescue persons in danger. This is the beneficence, what the beneficence says. It is worth emphasizing that the language is one of the very important. So whatever we are doing when we are talking to the patient, when we are explaining the things to the patient, we are taking the history of the patient, language must be kept in the mind. We should talk to them in very easy language which the patient understands. Go down to that level so that the patient understands you. Like a patient who does not understand English, we should absolutely avoid talking in English. non-malfeasance, harm the circumstances. Another is not to harm. If you're doing something, it should not harm the patient. The models, as I have already told you, that it supports the more some of the models also, and also the ethics. The practical application of non-malfeasance is it is for the physician to weigh the benefit versus harms of all interventions and treatments. So, whenever we are doing any intervention or giving medicines to the patient, we must weigh whether there are more benefits or more harm to the patient. To avoid those that are inappropriately burdensome or they cause harm, so we must avoid all those things which can cause harm to the patient. Different patients, its situation is different patient, different things to avoid and do to choose the best course of action for the patient. And this is very important, particularly, and it is pertinent in difficult end of life care decisions. That is when we have to decide whether we should withhold and withdraw life-sustaining treatment, medically administered nutrition and hydration, whether it should be. I'll give you and other intense. So when we are giving the medicines, we even have to give opioids. So that time we must because there are always certain side effects. So we must see whether there's more benefit than the side effects. So sometimes we have to forget about the side effects, which are much less than the benefits of the giving these drugs. And opioids I especially mentioned because they have a lot of harmful effects. So we must override the foreseen. We know that they are there, but unintended harmful effects of. We know that they are going to be harmful for certain. There's going to be certain harms, but because we know that it's going to benefit the patient, we can give, and this is called doctrine of double effect. Third is autonomy. This says that all the persons who have power to make rational decisions and moral choices. All persons, all patients, they're kept to decide things for themselves. This ethical principle was first in 1914 with the dictum. He said, the dictum was passed that every human being of adult years, that means adult years in different countries, they can be different. For us, the adult age of becoming adults is 18 years, Nepal, as well as so in different countries, it can be different. Everyone who is an adult, 18 plus, and 18 and 18 plus, and of sound mind, has a right to determine what shall be done with his own body. So a person and a patient, everyone, each one of them, they are masters of their own body. They have to decide and they can decide what should be done with their own body. The principle of autonomy does not extend to the person who lack the capacity and competence to act autonomously, like infant and children, like I said, persons below 18 years, and all those persons, all those patients who are incompetent due to developmental, mental, or physical disorders. Whoever cannot decide so they are, apart from these conditions, people who are mentally unstable, it is good or bad for them. The adults can, and adult and medically, so mentally fit people can decide for themselves. So respecting the principle of autonomy, the doctor should disclose medical information, treatment options, and exercise. Ask the patient for exercising self-determination after listening to all the medical information and also the treatment options. So this will include three things: informed consent, truth telling, tell the truth, and maintain confidentiality. These three things are very, very important when we are talking about the autonomy. Let's see, what is informed consent? Informed consent, each one of you at your, those who have already done third year, the second professional, where in certain cases, 6th, 7th semester passed, we've already told you what is it. So let's revise it. The requirement for an informed consent for medical, surgical, interventional procedures or for research also are that number one, the patient must be competent to understand and decide. Receive full disclosure. We are going to for a particular surgery we are going to do, and this is and these are the options. There are other options. We first tell the patient, and then how long it will take for the surgery, how long what kind of anesthesia has to be given, the stay in the hospital, how long the patient will need to stay in the hospital, how much it is going to cost for a patient, and finally, what can be the side effects. Everything should be disclosed to the patient. And we must show that he understands this disclosure and he acts voluntarily and consents in writing for the procedure. So we have to take written consent, which should be informed. Informed means we have to tell each and everything about the procedure and answer the questions which the patient asks and clarify each and everything. Here I must add here that about the informed consent, anybody who is above 18, sound mind, must give his or her own consent, written consent. We've seen the cases where for an adult, his father gave the consent for the surgery and the patient didn't know. He was not told everything about it. He was not disclosed all the details. The father was told about all the details. And when he came to know after the surgery what has been done to him or on him, he was very upset. And he said, why was not his consent taken? So he sued the doctor and he said that I did not consent for this particular procedure. So we have to be very careful that unless there's an emergency, person is unconscious, he cannot decide for himself. That means he's not conscious. He can't make the decision. So we must follow the core principles of human rights that we would wish to see honored universally. And despite variation in their superficial aspects are that there are local customs, local law, the religious problems, regional problems. So we cannot justify abuses of certain fundamental rights because of those things. So, and we cannot forego the right of self-determination on which the doctrine of informed consent is based. So, we should see to it that all those things do not interfere. So, you must tell each and everything to the patient. Then let him decide what to be done or not. Second, after the informed consent, truth telling. It is a vital component in doctor-patient relationship. Without this, the physician loses the trust of the patient, and a mentally fit adult patient has not only the right to know of her diagnosis and prognosis, but also he has the option to forego disclosure. He might say, no, please don't tell me. So, first of all, if he wants to know, he must be told. Don't tell lies to him. Don't tell other stories. Straightforward information should be given to the patient. Unless he has the option, he says, no, he does not want to know. And one should know, we must know, the treating doctor must know which of these options the patient prefers, whether he wants to know it or he does not want to know the full disclosure or half disclosure. Full disclosure to the patient, however, the grave the disease is the norm now. These days, it was not in the past. The doctors did not tell everything to the patient, but these days it is very important to tell the patient each and everything, and this is a normal thing these days. What happened before was that there was a resistance by the doctors for this full disclosure. In 1960s, most of the physicians, they preferred to avoid diagnosis to the patient or even to the attendants. By 80s and 90s, however, many of them favored it. Many of and present day situation is much, much better. Why it is much better? Let's see. This change of attitude is attributed to many factors like educational progress. Lots of people, as compared to previous years, previous decades, I would say, they are much educated. Socio-economic progress. Increased accountability to the society. We owe to the society because public is more aware of its rights, and they know, as we all know, Google and other things, they know much more than what we want to tell them. They already know all that. So, and it is their right to know more whatever we are doing to them. And also they know we must tell them what is right or wrong, what is ethical or unethical, and what is against the law of the nation. We also know this, and the patients also know this. Patients' attendants also know this. What is ethical or unethical, and what is against the law of the nation, which is very, very important. All fault of the doctors, and they're going to the court to sue the doctor for negligence. So we must be very, very careful about these things. So these days, wish to be, if they're telling, we must tell them the truth, what exactly is the diagnosis and what is the prognosis finally, after the treatment, without the treatment. So full information should be provided very tactfully in certain cases. Some patients are really sensitive, so we have to be very careful, tactfully we can give. They want to know, you should act very tactfully and with a lot of sensitivity to the patient. We have to be very careful in what language, in what words we have to tell it to the patients, those who want to know. And that should be our standard practice, which is very important. This is the standard practice. We should abide by this. We should make it our moral that we are going to do this, and this is our moral. Ethical duties, of course, there, but the moral, we should make our own moral, our own standard, that we must tell all these things truly to the patient, to each and every patient. Because there can be very sad consequences of not telling the truth. Why they want to know? Because if we don't tell them, supposing a person is terminally sick and he is not going to live very long, so we are depriving the patient of an opportunity for completion of important life tasks. Giving advice to, they might like to give advice to their children, their son, their daughters, the wife, and taking leave of them, putting the financial affairs in order, including division of assets or making will, etc. So if they know they're going to go, they will do all these things, even if they are demoralized, but they like to do all these things. Reconciling with those family members with whom they have not talked for ages, and friends, whom they did not, maybe they have fight, maybe they were angry with each other, they were not talking terms with each other, so they can reconcile with those people. Now, since I'm going, so I must make it up. Attaining spiritual order. We all, as we know, Indian, Nepalis, we all believe in God. So prayers, rituals, religious sacraments, etc. This all can be done if the patient knows that his life is limited years. So full disclosure to the patient is highly variable from country to country, as we know. In certain countries, it is the full disclosure, every each and everything. Certain people may not. So a well-practiced pattern in our societies is for the physician to disclose the information to the family and not to the... This is what, most of the time still, the doctors think that we should tell it to the family and avoid telling to the patient. Unless the patient is really educated, especially to those who are not very educated and those who don't know about their rights. So this resistance of the physician is to convey bad news, because it's so difficult to convey the bad news to the patient himself, because the doctor thinks that it might cause anxiety and loss of hope. The patient might lose hope and might cause anxiety to them. And we are doing the treatment, we are still going to give him. The patient may not be able to understand the information due to stress, etc. Or if they don't want to know, then it's okay. If they don't want to know, many people, they say, no, we don't want to know. So they can be, there has to be just choice. So a careful understanding of the principle autonomy reveals that autonomous choice is a right of the patient. And another thing very, very important is that the patient who is very well informed himself, but in exercising the autonomous right of autonomy, may authorize a family member or members to make decision for him or her. This is again a very important point, that many patients, they don't want to know, they leave, especially the elderly people, the dependent people, they leave their decision to their children, or the female might say, my husband will decide. Whatever decision the family takes, they abide by that. So the patient has this right that he or she can authorize another member or more than one member of the family to decide. And this is most of the time, this is what happens in India, Nepal, etc. Many times. Third thing, the first was informed consent, second was truth telling, and third is confidentiality. We must maintain the confidentiality of the knowledge which we come to know about the patient's disease. And this is called professional secrecy, that we must not disclose confidential information given by the patient to any other without the patient's consent. Exceptions are there with implied consent of the patient. Implied means that when he comes to you, that is understood that he's given the consent. Sharing of medical information for the care of the patient, for the benefit of the patient, from the primary physician to the consultant. Supposing you are the primary physician, you are the first doctor, but you have senior people or the consultants to whom you can consult them, and any other family the member of the healthcare team. So that is understood. That is implied consent of the patient, that we can discuss his or her problem with the consultant, with the senior people. So this should not be taken as, losing the confidence, disclosing the information. This is sharing for the benefit of the patient's disease. In present day, modern hospital with multiple points of test and consultants and the use of electronic medical records, there is erosion of this confidentiality. Everything goes on record, it is right. So many people can have access to that, they can open and find out the patient details about the exercise discipline in not discussing patient-specific problems, the secrets, their disease with their family members or in social gathering and social media. So this is obligation on the doctors who is treating the patient, that he must not disclose whatever information he gets from the patient. He must keep all that to himself, or he can at the most discuss with the consultant for the beneficial. But don't do it. Go keep on telling whoever meets you. Don't do that. Then there is privileged communication, the conditions in which we have to part with the information. These exceptions are because you have to divulge, again, for the benefit of the society and other people who are very closely related or in contact with the patients. That, number one, under court orders, then you must go to the court and disclose. Again, when you go to the court privately with the judge. Second, report it. Activity somewhere where this was received. So we are bound to report it to the police. Police information is a must here. Then sexually transmitted diseases, we must tell it to the concerned people, the wife of the person, or other people who are closely in contact with the patient. Except the situation that may cause major harm to another person. That is, in epidemics of infectious diseases, we must tell the proper authority. Partner notification in HIV disease. If one of the partner has HIV positive, then we must tell it to the spouse that the person has this so that they don't have physical contact with each other, sexual contact for that matter. And certain generics risk in certain patient that also should be notified to a particular relative, whoever is more concerned about it, not to everyone. Then the third, the next thing is justice. The justice. Justice refers to the fair. This is code of ethics, the fourth code of ethics. Justice refers to the fair, equitable, equal, and appropriate distribution of healthcare resources. This I'll give you certain examples of this. Of several categories of justice, the one that is most pertinent to the clinical ethics is distributive justice. Distribute, when you're doing certain things, distribute it properly, equal share to each other. How can this be accomplished? Principle of distributive justice that to the each person, each patient, there should be equal share. Equal share means it can be attention, it can be medicines. If there are limited resources, use of that according to the need, according to the effort, according to the contribution, according to the merit of the case. So all these things are often combined in application. We can't pick and choose, they're generally combined in application. So it is easy to see the difficulty in choosing, balancing, and refining these principles to form a workable solution to distribute medical resources. Tell you what. Like, for example, allocation of limited resources, especially in pandemic. We have limited medicines. We have limited, for example, somebody needs ventilator. We have limited ventilators, limited equipment, test, medication, organ transplant. You know, there are many people waiting for kidney transplants, but we have available kidneys are lesser in number. So all these things have to be seen as per the patient's needs and merits. Allotment of time for outpatient visits, equal time for every patient based on the need or seriousness and severity of the disease is very, very important. It should not be based on social or economic status. Somebody is poor, somebody doesn't belong to, belongs to a poor economic group. So we should not be treating them differently. They should not be, we should not be biased about anything. We must give resources. So we have to be fair to the patient. That is our primary importance, especially when there are conflicts of interest. For example, when a particular option of treatment is chosen over others, this is the option, but we have not chosen this, we have chosen this one. Or expensive drugs given over an equally effective but less expensive ones. You give more expensive drugs, the medicines to a patient. You opt a treatment which is maybe more expensive. So, and this is because it benefits the physician financially or otherwise. So this is very important that one should not be doing these things. There are four principles. of ethics. All these four principles, whenever there's cases, two things come that where we have to decide whether we go do this or we do this, whether this is better for the patient or this is better for the patient. So there will be conflict between the principles in many cases, many patients when we are dealing with the patients. So when we are faced with such conflicts, the doctor has to determine the actual obligation to the patient. We must see what is more important, what is more right in that particular patient. From patient to patient, we have to see. And this is will be based on number one, the disease, diagnosis, and management. That is the content and the context, the way in which the professional, family, religious, financial, and legal factors influence the clinical decisions. There's so many. These are also the factors which will affect our decision. So we have to keep both things. We have to keep the disease in mind, the diagnosis and management, and also the other factors which the patients, from each patient, they will differ. So we have to keep both the things when we are finally deciding about the patient's benefit or whenever there is conflict. Example, a patient in shock. A patient is in shock and is treated with fluid resuscitation, indwelling intravenous, has to be given. So what happens is that this indwelling intravenous catheter might cause pain and little swelling, but then overrides that we are causing pain to the patient. But then it is more beneficial. We have to give the fluids, intravenous fluid. We have to we keep the the line going on. So for that, we have to see whether the benefits are more or the harms are less. So in this case, must keep on giving this, looking after the pain of the patient. Also, of course, we can give some medicine. So here, the principle of beneficence is more important than that of non-maleficence. Many of the conflicts that the physician face, however, are much more complex. That was a very simple example I gave you. Intravenous infusion of fluids which can cause pain and swelling at the site. That was a very simple, and we don't have to think much about that. Simply we keep the fluid going on, and we are not much bothered about the swelling or little pain. We can give the painkiller to the person. We have much complex decisions. For example, a patient refuses. Either he refuses a life-saving intervention, that is starting mechanical ventilation. He says, no mechanical ventilation for me if the patient is, conscious. He can decide for himself. Or withdrawing the mechanical ventilation. The patient's relatives, they might not want to remove the ventilation, but because it's of no use now, but they don't want you to do it. So either the patient or the patient's refusal for certain things, or the refusal of their relatives, next of kin can be, and that is the time when the situation is very complex and decision making becomes very difficult for a doctor. So, why it happens? Many a times, the reason is when there is no disagreement between physician and patient is that they both think the goal of the treatment they have different people to convey to the patient or the relative of the patient properly. So there becomes a conflict, disagreement between the doctor and the patient or the patient. Because there's another reason also, because we are treating a patient and something happens, while we are treating the course of the disease or course of the treatment, the things can different. The things can change and the goal of the treatment can become different. This you people who are dealing with the patient, I'm sure you must have many a times faced this problem. Like a chronic neurological condition worsen to the point of needing ventilator support. Suppose you're treating a patient and suddenly there is problem and suddenly he needs ventilator support. The patient, obviously here the patient will not be able to decide, or even if he can decide, he might refuse, he might not agree. He might say that, oh, you didn't tell me this before, that I'll be needing, or the relative of the patient might say, oh, he was okay. Why is he not needing ventilator support? Or a cancer that is not responding to the treatment. You're giving the treatment, but patient is not. Their goal becomes defined, not be able to. And that is what doctor wants to do to the patient, and they don't want the doctor to do it. There the conflict of interest comes. So it is very important for the physician, the doctor, to communicate with the patient in very clear, straightforward, and easily understandable language without the use of medical terminology. So make the patient or the relative of the patient sit and straightforwardly, easily understandable language. Tell him, don't use medical terminology. They won't understand that. So very clearly tell them that this is the case, why we are now trying to take a different course of treatment. And with the aim of defining the goal of treatment under the changed circumstances, we must tell them all this and try to make them understand all this. Don't lose your patience, don't lose your cool for them. But in doing so, we also keep in mind that the factors which the patient might have, he might not be able to decide certain things because of his fear, pain, lack of trust. It's very important. Their anxiety is so much that things keeping in mind, we must communicate to them and do it with the patience, very patient mind, and in their language, of the language the patient understands. This was all theoretical discussion about the principle of ethics, which is application to the practical. We all know that in the clinics, we were taught all these things, which I've written. Each and every student was taught how to take the history and how to examine the patient. We must take the past history, history of present illness, family, social history, and then we examine them properly. All the systems should be examined, physical examination, and then whatever is test, laboratory test, other things, imaging studies, etc., have to be done. This we were all taught. This is the thing we always keep in mind whenever this is how we go about examining a patient goal of care and finding the preferences of the uh, on the treatment option of the patient. Don't decide for yourself. Talk to the patient and let him also decide, think and decide what exactly he wants. What exactly you will tell, you will explain, but then finally it is for him to decide what exactly he wants. And also keep in mind the quality of life, the effect of the medical problems, interventions, treatments, we on the patient, we must be aware that what exactly the individual finally will have quality of life or not. With this treatment, whether the quality of life will improve or it is acceptable quality. Family culture, the religious, spiritual, cultural, family factors. There are also economic factors. Whether the patient can afford this particular treatment or not, and then the legalities of that, whether it is legal to do this or not legal at all. So we must, these are the things we must keep in mind. These are the ethic when we are dealing with the patient. This we don't need to say. Okay. Now, having said all theoretical thing, let's discuss a few cases. I'll give you a few examples, the cases, and let's see what is better for the patient in these each and every case. We'll try to discuss different cases. The first case is where it was a young college student and lived in the hostel, and he was brought by the friend. Obviously, there were no family members, so and he was anyway investigated, everything done, and diagnosis was made of bacterial meningitis. So he was given appropriate antibiotics, and he was suggested that he has to stay in the hospital for the treatment. Although in the beginning it was implied consent that he came to you, you have started the treatment, you have given the suggestion. But finally, because of the bacterial meningitis, inform the patient of each and everything, whether it is painful, not painful, whatever, the details. And he was informed about this lumbar puncture, and the patient refused the treatment. He said he wants to go home and he doesn't want to stay in the. He was also told about the seriousness of his illness and the dangers to life if he goes home, because he can even be he can even die if he does not stay in the hospital and get treated. But the patient still refused. Now, this is the situation. Is it ethically right to treat this patient against his will or not? Well, it is, there are two things. Since the patient is suffering from meningitis, although there is no mental incapacity, disability, there's nothing, it's not clear, but then we can presume that the patient is in not such a condition that he can decide for himself. He's suffering from meningitis. He is slightly, obviously, delirious also. So he might not be able, maybe he's not able to decide the right or wrong thing for him. So here, the principle of beneficence benefit the patient. What he says, he doesn't want to stay in these two factors. What is better for the patient and mentally in the is not able to decide for himself. So, in the best interest of the patient and keeping in mind the temporary mental incapacity and the severity of life threatening illness and the urgency to treat and save the life of the patient, the decision should be in favor of beneficence. That means we must go ahead for the treatment. He needs the treatment, otherwise, the patient will die. So, here the principle of beneficence takes the first, uh, you know, it is taken into account, then the autonomy, whether the patient wants it. So, in favor is beneficent, that we must treat the patient even against his will. We have already started the treatment and we must continue the treatment. And in the meantime, if he keep on telling him that this is the best thing for you and tell his friend also that this is best for him. Second case, a middle-aged male who was a heavy smoker was diagnosed with lung cancer. Patient in consultation with the thinks that the surgery is going to kill him. And even explaining to him time and again about if he does not get the treatment done immediately, there'll be low mortality and the surgery is not going to do any harm to him, it's not going to kill him. And also if we don't remove the mass, it will spread. He continues to refuse the treatment. Now, what should we do in such a case? Cure and delay in its removal will increase the chances of metastasis and reaching incurable stage. The choice by this well-informed and mentally competent patient should be respected. So here, the autonomy will prevail upon beneficence. The patient is in 100% in his senses. He understands each and everything. Still, he does not want to get treated. But then we should not abandon the patient. We should offer to continue outpatient visits and advise him against making decision on fear, like keep on giving him psychotherapy that nothing is going to happen even if you go for surgery. You must go for it, and periodic examination, test, etc. Everything should be done, and also he should be asked to take second opinion if he wants, and try to convince him for the treatment. But if he still doesn't understand, we cannot do it. So autonomy is here prevails over the beneficence. This is the second case. Another is an old male who is suffering from severe COPD, admitted in the intensive care unit. and with all the symptoms, and he's intubated and mechanically ventilated also. That he's been going to the hospital, in and out of the hospital many times, and every time he had 3 admissions, and every time he was admitted in ICU, and also in those occasions he required intubation and mechanical ventilation. So his past history was also very positive. With proper treatment, everything given to him, treated his COPD, treated and ventilated, everything was done. The treating doctor, he is finally going back and back. He's not increasing. His oxygen saturation is not coming up even after oxygen. And his creatinine has risen, and he's drifted into comatose state. And he's conveying that he is going into multiple system failure. So the treating doctor suggests to the patient's relative that for the discontinuation of medication and mechanical ventilation as a continued use of no use. This is what he suggested to the patient. Because there is multi-organ failure, pre-existing end-stage COPD, and medical intervention is not going to reverse the stage where he is. So it is said that they are clinically, all these things are clinically non-beneficial. You can't say in this case we can even say they are futile, because they are not going to benefit the patient at all. So discuss with the patient's family with the goal of discontinuation of life-sustaining interventions. And these discussions have to be done very carefully, with sensitivity, compassion, empathy, and obviously, and even beyond if it is needed. So in these cases, if the family of the patient wants, they are convinced that it should be discontinued, the life support system should be discontinued. And everything should be told to the patient with sensitivity and compassion. Another case, a female who's a widow and suffering from living with her son, old female, was diagnosed as pancreatic cancer. And the chemotherapy, although it's not likely to cure, but would prolong her life. But the son requested the doctor that if whatever is there, the mother should not be informed. And even if there is cancer, etc., and nothing should be done because she's old and frail, she'll not be able to take it. So even when he comes to know that there is pancreatic cancer and she needs chemotherapy, he says no, that nothing should be done about it. Here, because the female herself, she's dependent on the son, and this happens in many families in India and in Nepal also, that you give your decision, the old people give their decision in the hands of either their husband, or this I've told you before also, or the children. So they make the decision most of the time. But the doctor is faced with problems, whether he should respect these cultural values or not. And he wants to learn the patient's preference directly. At least he should come to know from the patient what exactly the patient wants. And to comply with the full disclosure to the patient, although the son says, please don't tell her anything, but whether he should do it or not, and whether he should refuse the son's demand or he should go with it. So that is where the doctor is in dilemma, and he really is confused what to do or what not to do. The principle of autonomy provide that the patient the option to delegate decision-making authority to another person. She has the option. But you don't know whether she's really given this option or not because she's not saying. So you have to be very tactful, keeping in view the son's request. So you tactfully approach the patient and tell her that the diagnosed disease, you don't tell the cancer, that your disease would require decision for appropriate treatment, that your disease, whatever your disease is, you need the treatment for that, and ask her whether for that treatment, whether she will make her own decision or whether she would leave it to her son. So if she says she wants to make her own decision, then tell her what exactly it is. But if she says, no, my son will make all the decision for, then okay, then go by that. Then let the son make decision because he does not want the treatment. So autonomy, here also the autonomy is more important than the beneficence because the patient has designated her son to take all the decisions, and if the decision of the son is that she should be just left like that, let her live her life peacefully, whatever she has to live, whatever the years or the time, months she has to live. So let her live and don't complicate her problem by giving her chemotherapy and others because she won't be able to take it. Another case of cholecystectomy in a middle-aged person for gallstone. This is very important case. Forensic medicine is all about this and other things also, but this is very important in this particular case that she was operated and she was treated and she was all right to be discharged. She went home. 3 weeks later, she came back with fever, abdominal pain, and tenderness. Again, she was given antibiotics. But her fever won't come down. So they thought of opening up again, doing the laparotomy. And on laparotomy, what they find is that there was a sponge left behind during the cholecystectomy, which was done 3 weeks earlier. So, whatever, and extent of his error or not. Truth telling is also a part of patient's autonomy. So, this is very much applicable in this situation, that disclosure to the patient is required. The mistake caused harm to the patient in terms of morbidity, readmission, second surgery, and monetary loss, etc. So the surgeon is obliged to inform the patient of error and offer an apology. Also he should inform the hospital authorities so that the compensation can be made in terms of money, at least. And the apologies, at least say sorry for whatever has been done to her. In these cases, the criminal negligence suit going to the court is very possible if the patient comes to know. She was not told at all that the sponge was left inside and everything happened because of that. But luckily for the doctor, the patient goes to the same surgeon. And she was treated and with total secrecy. But the honesty of the doctor reduces the threat of legal claims. So if he tells her, he says sorry for that yes, it was unintentionally done, and then the patient might think that, okay, the doctor has honestly told everything and it said sorry to that, and they might not go to the court. In case patient had gone to another doctor instead of going to the same surgeon, they go to another doctor, and there the sponge was found on investigations. The patient can file criminal case against the doctor for professional negligence, that is, and negligent, whether unintentionally, but the doctor was negligent, and the doctor had total control over the whole procedure, and if he was not negligent, this would not have happened, and there was no contributory negligence of the patient in this case. So doctrine of res ipsa loquitur will apply, and the patient does not have to prove anything. It is already proved, and it is the doctor who has to defend himself. So it is better for the doctor, this doctor, to tell honestly, that yes, it was by mistake that this happened, and also the authorities, hospital authorities, so that at least they can be compensated for the monetary loss. And saying sorry doesn't harm anyone, not the doctors at least. So this was a clear-cut case of negligence, and it comes with criminal negligence. But if the doctor says okay, then the patient might not go to the court at all. Now we have come to the final case, which is very dicey. We are dealing with two patients here during COVID-19 pandemic. An old retired nurse came with all the symptoms and was COVID positive. And while she was being examined and investigation done, another boy, a young boy who was a medical student, also came with the same symptoms, COVID positive. He was also admitted in the. So we have two patients, but unfortunately the hospital has only one ventilator available. And in these two cases, who should get the ventilator? Old patient, a retired nurse with comorbidities, she had comorbidities also, and a young, previously healthy medical student as a patient. So we have these two options. The patients, both are important, the lives of both are important as far as they are concerned, and as far as the treating doctor is also concerned, ethically. Not everybody can live. This is the question. That everybody can't live, but then who shall live? Who is the priority? Who should be living? This decision cannot be emotional driven or based on personal whims. Nor should it be based on person's wealth or social standing. So priorities need to be established ethically and must be applied consistently in the same institution, ideally throughout the state and country, Like if such patient come, what are the principles, what are the priorities? They should be well defined in that particular institution, and they should be equal in throughout the country or the state for that matter. So what happens if such cases come? What do they do? Maybe previously, what did they do in previous such cases? So should be done in the present condition also. The general social norm to treat all equally or to treat on first come first serve basis is not the appropriate choice here. Here, generally it is, the first come and first serve basis. Generally it happens. She came first, so she should be given the ventilator first. But here in these cases, in this particular case, this type of case, this is not appropriate choice. What what is done? What should be done? What is the consensus among the clinical ethics scholars? That in this situation, maximizing their benefits is dominant value in making the decision. Maximizing benefits. Maximizing benefits can be viewed in different ways, like number one, on lives saved or in life years saved. Which life should be saved? Should be saved. Which patient is for the, in this case, for the hospital for that matter. Priority to the patient who have a better chance of survival. This is very important. Priority to the patient who have a better chance of survival and a reasonable life expectancy. And the sickest and the youngest. So scenario of these two cases is what the decision you make depending upon all these maximizing benefits, but it is so taxing mentally for a doctor to decide. So when you decide in favor of one patient, so it is not peaceful decision and it is not a fully satisfactory resolution for a doctor to decide. Me, for instance, from several decades of experience in teaching and mentoring, I anticipate and expect physicians with qualities of both heart and head. Ethical and humanistic values shape the former, that is the heart. Ethical and humanistic value, that is from the heart. And head will sell the knowledge by studying, research, practice, technical skills, etc. Then medical and surgical procedures, etc. They will form the of the head. So, was decided was that the young boy who is more beneficial, very old patient, female, although she was also a nurse, could be of great benefit for the other patients, but she was old and she had a lot of comorbidities and she was anyway not going to survive for a very long period. So the life years added would be more beneficial to the younger patient. He's more benefit to the society and his profession in the long run. So for all that thing, keeping in mind, they give the ventilator to the younger patient because the older patient is anyway, even if you do that, you're harming both If you give the ventilator to the old female, this time she might survive, but next time she may not survive for a very long period. So, and you're going to kill the young patient also. So, the ventilator is given to the younger patient, keeping all those things in mind. And this decision is many a times not left on the doctor, the nurses who are, with the doctor treating while the doctor is treating this case, and other healthcare people, all those who are linked to this case, they are not the ones who should make this decision. A committee is made, and they are the ones who decide, and they make the rules, the general rules for the hospital, that such cases come and this should be the course, so that it is not taxing for the doctor and he does not feel later on. It's not disturbed mentally because he took the wrong decision. We have to keep all these things in mind. I will just summarize principles and some virtues. Compassion, very, very important. Caring, sympathy is expressed. We've already discussed this. Judgment is especially valuable in decision making when the ethics collide. Trustworthiness leads to trust, and it is needed when the patient are at their most vulnerable time. They are so sick, they're in your hands. Place themselves in your hands, and they, trust you to do the right thing for them. Trustworthiness, integrity, both professional integrity and personal integrity. So both of them. Personal monetary gain is placed over the patient's welfare. That is the integrity. Prescribing ineffective drugs or expensive drugs when inexpensive drugs are available. We have cheaper drugs which are equally good, but we are giving expensive drugs to the patient, which might be lesser effective also. And then doing invasive, treatments or experimental research, etc., without fully informing consent. So these are these are the issues of integrity. One must maintain professional as well as personal integrity, and patients' personal gains, monetary or otherwise, should not be placed first. Conscientiousness is required to determine whether the right, good versus bad, better versus good, logical versus emotional, and right versus wrong, etc., must be, all these things should be weighed and then decided. Caring, very important. Caring is very important. How you care, the secret of care of the patient, they say, there's a saying that secret of the care of the patient is caring for the patient. It can be caring, can be verbal or non-verbal. Verbal can be when you're very nice to the patient, you talk to the patient nicely with lot of care and empathy and sympathy. Softly spoken words, don't lose your patience. And non-verbal is when you touch a patient, conveying bad news, very gentle touch, or another, firmer touch, firmer grip in difficult treatment choice, etc., or to hold the hand of a dying patient. This is the how you care for the feeling of the person. So thank you very much for the very patient listening. Any questions if you have, please. There were some questions which already have been given to me by you people. The some of the questions have already been answered automatically in this, like the morals and the ethics, which we have already. What is the difference between morals and ethics? Morals are your personal principles, where ethics we already know what the ethics are. They are both related to differentiating good and bad, right or wrong. But morals are personal. For example, I'll tell you, morals, adultery, for example. I'll give you this example. There are so many examples. Adultery. In certain countries, adultery is not a very serious. In our country, it is, but in certain European countries, so-called advanced countries, adultery may not be a very serious thing. That is their morals, their ethics. But your morals can be that you are not in favor of adultery. So that is your moral. Their ethics, your morals. So personal are morals, whereas the ethics are the general things. There are so many examples, that taking drinking alcohol in Western countries is not supposed to be nothing bad about it, but especially females. But in our societies, or personally, some women might feel that no, for her it is not her principle, the personal principle that she doesn't want to drink. So that is the moral and difference between the moral and the ethics. Another question was forensic medicine as career. Are you hearing me? Please, somebody say yes. Can you hear me?
Yes, ma'am. Yes, ma'am. Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Okay. If anyone has any question, even after that, please come out with that. But for anybody, I would say anybody who is interested in earning money, if money is the criteria, then forensic medicine is not the subject for you. Although money is criteria for most of us, but it's not that it's not paying. It does pay. They pay you well. But if lot of money making is your criteria, then one should not think about this. But it is very adventurous and very exciting as a medical career. We have different branches, and you can do further studies, you can do PhD degrees in different branches, and you can go abroad as forensic expert. They call them forensic pathologists there. And I have a friend who is doing excellently well, who is dealing with only forensic psychiatry. She's a forensic psychiatrist in UK and doing extremely well. She's earning a lot, if that is the money part I'm talking about. And then the certain advantages are there. that you make amazing contacts with police, with VIPs, etc. There are many people these days. They left. Mine is no more. He's dead. He was very young when he died. He left his job. He was a very brilliant doctor. He did his MBBS from All India Institute of Medical Sciences. He was my colleague when we were doing post-graduation together there. And he left this when he became professor also. He left and he went into private sector and he was minting money. The way, like, it was not wrong. He was not doing anything wrong. Only giving consultation, medico-legal consultation to the parties. Rights of a doctor. They say that we are generally talking about but we are not talking about patient. Well, we have lots of rights also. The rights of the doctor, we have fundamental rights which all other citizens of our countries have. All those fundamental rights also are there. And then we have special rights. We have a right to refuse to take a patient, a right to refuse a patient on grounds which are there. Whatever your reason is, you don't even need to give reason for that. Refusal of treatment, even to a particular individual, unless there is an emergency. Emergency, one must think of taking the patient, giving the first aid and referring the patient to either another doctor or to the hospital if the hospitalization is needed. So emergency should be taken as, see, nobody is going to kill you for not taking that patient, but ethically or even your moral principles will not allow you to see a patient bleeding, a patient of accident bleeding right in front of you and you not giving first aid to them. So you must give the first aid and refer the patient to the hospital for further treatment. And you can also refuse an intervention or a procedure which your conscience does not allow. Suppose you're working in a private hospital and your conscience, a patient does not need that particular intervention and your conscience does not allow. Your morals, your personal morals don't allow. Although the hospital ethics might say that you do this, but you can refuse. That is your right to refuse. A right to use the title of qualification, a right to prescribe and dispense medicines, a right to charge the patient, take your fees and other expenses. That's your right, and you must take that. Whatever your fees is, whatever your expenses are, you have to take it from the patient. You should. That's your right. You have a right to issue medical, but the true, not the false certificate, the true medical certificates. And it is your right to live with dignity, not to be maltreated by the patient or patient's relatives. And you have a right to protect in those circumstances. You have a right to protect yourself. And as in a very important case, very prominent case, the judge said that the doctor cannot operate with shaky or trembling hands. Meaning what? That if you're all the time, you're under the fear of being beaten, or the legal proceedings, then you cannot do justice to your job. So you have a right to protect yourself, and you must do whatever way you think is proper. And talking about responsibilities of the patient, patients have many rights, but also patients have some responsibilities which are related to the doctor, like it is the responsibility of the patient to respect the doctor and treat, whether it is a nurse or a compounder or a dispenser or doctor, whoever it is. Respect is the responsibility of the patient to respect them. No verbal, physical abuse to the healthcare persons. No damage to the equipment and other property of the hospital. There has been cases where in India, such people have been punished also when they went violent with the doctors, and they have been punished also to follow the treatment properly. That is the responsibility of the patient. Tomorrow he should not come and say that the doctor was negligent and sue him in the court, because that is called contributory negligence. If he does not follow the proper instruction, he must follow the proper instructions. He must tell the doctor if he is taking any other treatment, like he is going to the other doctors like homeopathic or other doctors also. Reporting anything if it is unsafe in the hospital, and accept the consequences. Many times there are, doctor is not negligent, but mishaps happen. Unfortunate mishaps happen. So in those cases, they should accept the consequences. Sometimes they come so late to the hospital, and the patient cannot be saved, and the patient dies, and they are violent towards the doctor, but which is not good. And then financial responsibilities, obligation should be fulfilled, whatever their fees is, because most of the time the patients are taken to the best hospitals, and they're very costly. If you are getting the best treatment, you have to hospital. That is, they become beating up either the doctors or destroying the property of the hospital. That is that. Oh, ये क्या हो गया? Oh, it has come. Somebody asked medical ethics in Nepal. Nepal Medical Code of Ethics and Professional Conduct, 2017. The first was in 1992, then 2001, 2002. Then the fourth edition was in 2017. This says that a person, it was said that a person may be a poor writer, a bad painter, or a bad actor, but he cannot afford to be a bad doctor. This is what the Nepal Council says, and Nepal Medical Council. But the basic principles of ethics are same everywhere. So the Nepal is also appeal cases, and the victim, the accused, and sexual offences, physical assaults, autopsies, age estimation should be carried out by not by forensic medicine. The rest of the ethics are all same And another very important question which was asked was about euthanasia. Euthanasia, since March 2018, when that I'll tell you later on, when the whether euthanasia is good or bad, that was the question. There are certain guidelines in different countries. Different things have happened. Some countries have also euthanasia. Patient who is suffering from such a disease, which is or pain which is incurable, and or passive is when you stop giving the life-saving drugs or the other treatments. So both the types, they are allowed only in certain countries. In Nepal, it's not allowed. Recently, they have allowed, in March 2018, allowed passive euthanasia. They become, but under strict guidelines. It is not a blanket decision. Blanket decision means it will not apply to each and every case. Each case will have to be presented to a particular committee where they decide whether it can be done, passive euthanasia can be done or not. So each case, that will all depend upon the patient's living will. If the patient had already made a will that if I suffer such and such thing, the life-saving thing should not be given to me or should be discontinued, or in very terminally ill patients, and if the patients are in vegetative state. In all those cases, again, the committee has to decide whether the life saving treatment and the ventilation, etc., should be continued or not continued. That committee will decide, and each case will be decided on its own merits. So here also we have both advantages as well as disadvantages. There are certain people who are against euthanasia, or they are, things which statements which are against. That means people with incurable illness, they say, some people think that if euthanasia is made legal, then all those people who are suffering from incurable diseases, illnesses, will be eliminated from the society. And there'll be no palliative care in those countries. Then it is against the constitution of the country, like right to life. And also it is against duty of the state to protect life, provide care and not to harm the patients. And also they say this euthanasia legalization might lead to less investment in healthcare. They think, okay, terminally ill, we don't need to do anything about it, let him die, or we'll help him to die. So they don't need to do further, studies, researches on that, or to save the lives of the patient. So there'll be less investment in the healthcare. Mentally ill patients are not able to decide for themselves, so it is not correct for them to, take this decision. If anyone else takes decision for them, then there can also be malified intentions, like people don't want to, their relatives or the children, they don't want to look after the patient, they're too tired of looking after the patient, so they can be malafide intention and they might want to get rid of the patient. Then also there could be interest in transplantation, taking organ for transplantation. Maybe that is the primary interest of some people. And then commercialization of healthcare. That is the one of the things which is in favor. Like let's see what are those things in favor. In favor is that caregiver, people who are taking care of these very terminally ill patients, that burden will be less. Burden are like financial burden, physical burden, emotional, time, and social burden. All those things, people who are only busy with terminally ill patient, spending a lot of money, they'll be saved of that. Secondly, right to refuse medical treatment is recognized in law. That is passive euthanasia. It is already recognized. Again, in certain countries, it is totally recognized. In certain countries, in India, like I told you, it is from case to case. Right to die. Patient of persistent vegetable state or patient in terrible pain, terminally ill, they have a right to decide for themselves. That is in favor. And also, organ transplantation can be both ways, that organs of these patients, if they are not damaged yet, they can be taken out and they can be given to other needy people, and many lives can be saved by doing euthanasia. In one case, we can save life by transplanting his organ into other patients who are needy. So these are certain good and bad things about euthanasia. There are always good and bad things about each and everything. And what else was there? Somebody was asking, what was that? Ethical issues faced by doctors. We've already done that. We've already discussed those. Few things which we've not discussed are like reporting unethical behavior of doctors, your own colleagues, again, which becomes very difficult at times. Gifts from the patients, pharmaceutical companies, etc. So those are also the things which are whether ethical, unethical. For certain people, they are ethical, so for certain people, they are not ethical. Dealing with the opposite sex, especially with the female, of male doctor treating a female, that can become ethical issue many a times. So that has to be dealt with. Well, it's a long topic, but the most important thing is that female patient should not be asked to strip. Secondly, patient should always be examined in the presence of a female attendant or her attendant, preferably, and consent for per vaginal examination, etc., should be taken prior to the procedure. So all these things should be kept in mind, which is then very, very important. Then we have legal problem all the time. There's fear of legal problems, and especially these days when a patient comes to you, he is so well informed. He's read each and everything about the disease, about the medicines which can be given, and what are the side effects of medicines. Nobody is bothered about side effects of what we are eating every day. You're eating butter every day, you're eating mutton every day, you're eating so many things every day. You're not bothered about the side effects of those. But when it comes to medication which is going to benefit the patient himself will come and say, these are the side effects the medicine is going to have. So, like, these are the things which are really half the time they're talking to you and they've already diagnosed their thing, half of it, and they're already telling you the treatment part also, discussed it. This is half the knowledge. If this was possible to do, then they would not be spending so much of money on the making of doctors. So, but the doctors are always in fear of these legal issues all the time. That's why it was said that a person who cannot operate with shaky hands, for that matter. So, all these things, when in cases of terminally ill patient, we must see that whether he is given living will or power of attorney, that is, he can give his, like we've already discussed, that a patient can always give all the decision-making power to his relatives or son, husband, etc. And so these were the main things probably. Then somebody also asked about general principles of toxicology. Although it is out of context, but we can still talk about it. General principle there are three types of toxicologies. One is like related to death investigation toxicology, postmortem, then finding out whether that particular thing the poison contributed to the death or not, lab diagnosis, viscera sending and all that, and dealing, and also dealing with the patients in private colleges in Nepal. They have not given the right to do medico-legal work. But in India, many private hospitals are also doing all the medical work, which is even in the emergency department, casualties. All medico-legal cases of poisons, fights, injuries, sexual offenses, everything is coming, burns, for that matter, death or patient of burn, etc., they're all coming to the emergency, and the doctors from forensic medicine department are the first one to see those patients and do the legal formalities, and then refer them to the particular departments for treatment. So, dealing with the patients also very, very important. Then we have behavioral toxicology. That means drunken driving. Although it's drunken driving in Nepal, it's an offense. In certain countries, it depends upon how much the blood alcohol levels are. So it will depend on that. In India, it is 30 mg% only. It was earlier 80 mg%. Now it is only 30 mg. If anybody found with more than 30% and is driving, that is an offense. So driving itself can be an offense when the blood alcohol level exceed, or otherwise drinking, if the levels are low, driving is not an offense. But when you do something, you meet an accident, you are cause for an accident, that is an offense. Or you pick up fights after drinking, that is an offense. And you hit somebody, you hurt somebody, cause injuries to the person, that is an offense. So drunken driving, sexual assaults after taking certain drugs, the many drugs which are used for such thing. Then the third one is sports toxicology. So we have behavioral, we have death investigating, and which is main, then behavioral, and then we have sports toxicology, where drug testing is done. Drug testing, bedside tests, before the employment, before the sports events, etc. And whenever there's a court order for drug offenders also. So all those, that is called sport toxicology. So principle of toxicology, I don't know whether somebody wanted to ask principle of toxicology or principle of treatment of poisons. Don't know. I wasn't very clear about this. Anyway, these are the three types of toxicology if you're talking about the toxicologies, general principles of toxicology only. Any other question, please ask. I'll be too happy to answer. If there's no question, then thank you very much for very patiently listening to me. And I'm sure very good audience. And it was my privilege to little bit of knowledge what I have to part with that and to share that with you people. Thank you so much. Thank you very much.
Thank you so much, ma'am, for such a wonderful session. I hope that most of our participants will be get benefited from that. And I would like to
I
apologize.
wish they had asked more questions. I would have loved to answer those questions. Anyway, we can be another time, any other topic, if they want, we can discuss relating to my
Sure, ma'am.
subject.
Sure, ma'am. We are also looking forward to do more such sessions. And it was quite a wonderful session, ma'am. Thank you so much, ma'am.
Thank you so much. Thank you very much. My honor. My honor.
And thank you to all the participants who are here. You can now download your participation certificate from the chat box. And let's end the session here. Once again, ma'am, thank you so much. We are looking forward to do more such sessions, ma'am.
God bless you all, my junior colleagues, my students, students of other colleagues. Thank you so much and God bless you all. Do well, study hard, and work very hard and do well in your best of luck for your future endeavors. Thank you so much. Bye.
Thank you, ma'am.
Bye-bye.
Thank you. Good night, ma'am.
Good night.